Thank you, Dr. Calafiore and Dr. Chan. I view my job as being sort of the intermediate here between my friends Steve Bowling and Rakesh Suri, who are going to talk about the two extremes about being very aggressive and very conservative, and I'm going to hit it right down the middle is the way I view it. So by way of disclosures, I don't have any that are really relevant. I invented the MC3 ring, but I'm not actually going to talk about that specifically. I'm supposed to talk about the not so forgotten valve, and the AATS about 10 years ago, I showed the slide on the left, which was the publications about tricuspid surgery, and over 10 years there were only 30 of them during most of the 90s. Things have picked up a lot, so there's a lot more that we know about the tricuspid valve and about tricuspid surgery, and so I'm going to talk about what we have learned. It's not as forgotten as it was. It is still controversial, though, which is why you're about to hear two different talks that are pretty polar opposite about how they treat it. So kind of as you go through this, I picture in my head a 77-year-old, or you could call a 57-year-old, who needs a mitral valve operation. And what do you do if they have 3 to 4 plus TR? What if they have 2 plus TR? And that's where it's a little more controversial. What if there's hardly any TR, but the annulus is dilated? And then does your approach differ if it's type 2 with prolapse versus ischemic or functional mitral regurg or type 3B? And then very briefly, because of time, I'm going to talk about patients with primary tricuspid disease, because they still are forgotten. We hardly ever talk about patients with just tricuspid disease. There's not a lot of help from the guidelines. These are the U.S. guidelines, and this is saying the obvious one, the class 1, is if you're already there to do a left-sided valve or a mitral valve and they have severe tricuspid disease, you should fix it. That's pretty obvious. And then patients that are symptomatic, in particular if that's a group of patients with primary TR, like patients with rheumatic disease, or it's secondary TR, but you can replace it if they're not amenable to repair, although the vast majority of these are amenable to repair. The important difference in the U.S. guidelines is this. It's class 2B, meaning you should think about it sometimes but not routinely do it, which is you can do an annuloplasty if it's less than severe in a patient who undergoes mitral surgery with pulmonary hypertension or tricuspid annular dilatation. And the new set of guidelines are going to be coming out sometime fairly soon, so it'll be interesting whether they still leave that as 2B. The other part that's interesting is that there's one section of the guidelines where they say patients with severe TR of any cause have a poor long-term outcome because of RV dysfunction and or systemic venous congestion. And yet it's a class 3 recommendation to actually operate on patients with asymptomatic tricuspid regurg. And think of the internal discrepancy with mitral regurg, where if a patient has asymptomatic mitral regurgitation, as long as you can repair that valve, that's a class 2A recommendation. But if it's the tricuspid, they make it a class 3, saying that you shouldn't do it. So the document itself is really not that consistent. Are they more enlightened in Europe? I think so. If you look at their guidelines, they're different, and they're probably, I'm going to guess, more where the U.S. guidelines will go. If you have organic TR and it's moderate, they make that a 2A. But more importantly, what's a 2B in the U.S. is 2A, saying moderate secondary TR with a dilated annulus over 40 millimeters in a patient undergoing left-sided surgery, and then they make it a 2A if they have severe TR and symptoms after left-sided valve surgery. So one of the messages hopefully you're going to get is that if you're there to fix the mitral, also fix the tricuspid so you don't get in that situation that later you have severe TR. But they say if you have severe TR and symptoms, you should operate on it. And then they made it a 2B, not a 3, that if you have isolated TR, even without symptoms, if you're starting to get RV dysfunction, which is, again, similar to the left side disease, that you should think about operating on that. In terms of the etiology, this one is several years old now, but this came from Carlos Duran, and he was looking at what happens to the tricuspid if you don't fix it with ischemic disease in particular. And as you can see, that early on, about 25% of the patients still had 2, 3, or 4 plus TR, but over time it got progressively worse. So by greater than 3 years, almost 75% of that group of patients had TR. And so what he concluded is that it's frequent in this condition of type 3B or ischemic MR, and after repair, about half of the patients will develop TR, and he suggested pre-op annulus dilatation might be the predictor of late TR. Well, so Dr. Calafiore and his colleagues also looked at something similar. Again, functional mitral regurgitation, so different than a bit of what Dr. Suri is going to talk about. And he said, so what happens with patients with moderate or more at the time they're treated, and looked at propensity. So this is looking at survival, and obviously the patients with treated did significantly better. And then they also looked at not just alive, but feeling well. And so this is the difference in class 1 or 2 heart failure. Again, if the patients have been treated, they did much better. It was a group of about 120 patients. And then what happened to the TR? In the untreated group over here, it's about 80% that had 2, 3, or 4 plus TR. But in the group that were treated over here, it was only about 20% that still had 2 or 3 plus TR. So clearly in that group during follow-up, they did better if you went ahead and repair it. And they also concluded that it's easy and safe, and it's mandatory if they have at least moderate TR in patients with functional disease. Well, Gilles Dreyfus looked at a group of patients that had primarily type 2, and this is a group of patients that really had almost 0 TR beforehand, but they have very severe annular dilatation, and he was looking at annular dilatation greater than 70 millimeters. It's almost like big enough to put your fist in there. It's pretty huge, and so half of them actually had repair and half did not. And what he found in follow-up is that if they had a repair, their New York heart was better, their TR was much better at follow-up, almost non-existent versus 2 plus, and very few of them had actually progressed over time. There's this study that is more recent, just from last year, and this is a prospective randomized trial of 44 patients that had prophylactic annuloplasty when they went through surgery. And this is a group that the indication was just greater than 40 millimeters that they would decide that they would add the annuloplasty. And so what you see here is the mean follow-up of TR. And in the group with degenerative, it looks different, but statistically didn't quite reach significance, 0.12, not very large numbers of patients in that group, but a big difference in patients with rheumatic disease, and again, in the group of patients with functional disease. They also found, not too surprisingly, that the group of patients that had tricuspid annuloplasty, the dark bars, actually had ventricular remodeling. The RV was getting smaller. They had some change in the TR grade, of course, and it was not related to the change on the left side because the PA was no different and the left atrium was no different. That's been shown before. This is Cleveland Clinic data with isolated tricuspid regurg showing a big drop in RV volumes after tricuspid repair. And then here's another paper. This one was also just published last year. This is looking at the group with mild to moderate functional TR. And again, this is the rheumatic group of patients. And what they're looking at is that the group that had repair did much better freedom from TR, and that's in group with a mild right here or with moderate down here. So again, they showed the same thing. What do we do at Northwestern? Well, I queried the STS database to see what happens across the country. If we have severe TR, dark bars at Northwestern, it was 100% were repaired when patients went through any mitral operation. In the U.S., it's about 80%. So sometimes even that group of patients with severe TR undergoing mitral are not being repaired in the U.S. For us, it's about 50% moderate TR. Like I said, I'm probably in the middle between Rakesh and between Steve Bowling. And then for this mild group of TR, we do look at the etiology, and we look at the tricuspid annulus and the age of the patient and so on, and do repair some of those. Sometimes it fails. I won't spend a lot of time on this. The group of 4+ tend to fail more than 3+. Suture repairs tend to fail more than bands or rings. This is the Cosgrove flexible band, but there is a difference in time. The classic Carpentier ring did the best, and Jose Navia updated that report just about 2 years ago. Patients with pacing wires, very specific to tricuspid, don't do well. And the big one is this. If the valve is severely tethered, then that's a group of patients that are very prone to fail. And I, in fact, now think about a replacement in that sort of 5% group. So every once in a while, we'll think about that group. And I have them turn the color off and just look at the valve itself without any color. Gilles Dreyfus has published this using an autologous patch for that group that have severe tethering. I have to admit I've tried it a couple of times, and I haven't had the same luck that Gilles has, but there may be tricks. I should ask him while I'm here to see if he did that differently. So in conclusion, the tricuspid is generally under-repaired, especially in the USA, but it's actually much better than it was 10 years ago. There's a lot of similarities of functional tricuspid and functional mitral regurgitation. A lot of the pathology is the same. If you fix the tricuspid, the RV usually will improve. Non-ring repairs are not very durable. It's been shown in several different studies. And then the big risk factor for recurrence is tethering, pacing wires, and 4+, and we're working on a percutaneous approach. Thank you.